Well, good morning, everyone. This is Sean Walker, and I am welcoming you to the third meeting of the Comprehensive Health Coverage Commission. The format of this meeting will follow the format of our previous meetings, where we invite the public in to view the discussion. The commission members, as well as their invited speakers, will have the ability to unmute themselves as needed to join the discussion. This meeting is being recorded, and within a few days after the conclusion of the meeting, we will post this recording on the commission's website. I'll pause right now to have the presentation brought up and shared. DeLauren, if you could do that. While she's doing that, I'll continue with the opening. So as I mentioned, in a couple days after the conclusion of the meeting, we will post the recording on the website so anyone can access that and see the discussion. Thank you, DeLauren. As we mentioned during our last meeting, if there are members of the public who want to join our distribution list to receive notices of upcoming meetings, you can do so by sending an email to the commission at chc.commission@dch.ga.gov. And that website is on the bottom right-hand screen of this presentation. All right, DeLauren, next slide, please. So today's agenda is displayed here. In a moment, I will perform the official roll call of the commission members. Then we will move into remarks by Chair Nagel. We'll introduce the consultant of the CHCC. Then we'll have questions and feedback from the commission members. And then we'll close out with new business and remarks by Commissioner Nagel. I'm sorry. Kaylee, Chair Nagel. All right, so at this time, I will ask the commission members when I call your name to please unmute yourselves and let us know that you are here. DeLauren, if you can move on to the next slide, please. Kaylee Nagel.
Morning, I'm here, and just seeing your note, I think Dr. Odom might be on, but not quite labeled as a co-host just yet.
Okay.
Oh, I think she just got him. Okay, thank you.
Yeah, no worries. Lisa Carnot. Pam Clayton.
Good morning, I'm here.
Good morning. Christy Klein Davis.
Good morning, I'm here.
Thank you. Delvecchio Finley. Dr. Hyman.
I'm here. Good morning. Thank you.
Good morning. Dr. Moore.
Here as well. Thank you.
Good morning. Thank you.
Morning.
Dr. Odom.
Present.
Good morning. Thank you, Dr. Odom. Rusty Ross.
I am here, and good morning to everybody.
Good morning. Thank you. And I'll come back. Lisa Carnot, were you able to join? Okay. Well, that concludes roll call, Chair Nagel. I'll turn it over to you.
Well, good morning, everybody. Thank you for joining with us. And I know we had some challenges with getting everyone's schedule to align this time. It probably won't be the last time we run into that problem, but we'll always do our best to get a time that works for most everyone. Today's meeting, I think we're scheduled from 10 to 12. I don't expect it to take the entire time. The main purpose of our conversation today is really to hear from the consultants that we've been able to secure through statewide contract with the help of DCH, EY, who will really introduce themselves and their team and walk us through the process by which we will really undertake this work. To date, we've heard a couple of presentations from DCH, the Insurance Commissioner's Office, and really did a little bit of a landscape analysis on current Medicaid and Georgia access and pathways within Georgia. And from there, I think we have a pretty good understanding of the lay of the land and how things work today. And so EY will now pick up and lead us through over the next 2 years a pretty systematic look at options and opportunities and things that we want to dive into. DCH is sharing with them some of the feedback from your questions and your comments, some of the input that you've provided offline as well, to really organize our thoughts and how we approach the work, kind of taking into consideration everyone's preferences and interests. And so happy that they were able to join us for this work. I'm looking forward to their leadership in this with us over the next 2 years. Not to be forgotten, we still do have a report that will hopefully be ready and out on December 1st. I think that's a weekend, so it'll probably be the following Monday if everything goes to plan. But EY is already engaging and starting to compile some information, and we'll certainly have some thoughts around that in short order. We'll certainly stay connected after this meeting as we get to that. But nothing's ready for them really to share at this point in time. But again, we'll take everything that we've heard and really just be probably a summary of what we've heard and done to date and laying out this roadmap and how we're going to approach the work going forward. But certainly, I think they're interested in hearing your feedback and thoughts on that path ahead as well. So again, plenty of time today to get through that. But I'm going to turn it back to Sean to introduce the EY team.
All right, thank you so much, Chair Nagel. If you can move to the next slide, DeLauren. So this morning, we are joined by Belinda Menta, as well as Julie Hicks, who are representatives from Ernst & Young, and they will walk us through some information that they provided to share with the commission today. Belinda, if you don't mind introducing yourself and then turning it over to Julie so she can introduce herself as well, that would be great.
Thanks so much, Sean. Good morning, everybody. Belinda Menta. I am a partner at EY. I've been with the firm for a little over 11 and a half years. Prior to consulting, I worked in the public sector, primarily focused on public health. A lot of the work that I have done with the state of Georgia has involved the various departments of Health and Human Services. So thank you for the opportunity to support the commission on this very important work. I will turn over to my colleague, Julie, to briefly introduce herself, and then we'll walk through the approach and the activities for the next 2 years that we'll be supporting the commission with. Julie?
Thank you, Belinda. Good morning, everybody. My name is Julie Hicks. I'm a manager at EY, and I've had the pleasure of working with about 15 different Medicaid programs in my consulting career, and really excited to join this very important initiative and support you any way I can. Thank you, Sean. Or back to Belinda, I apologize.
No worries. Thanks, Julie.
All right, thanks, Julie. So the way that the project is currently structured, there are 2 key phases, and these are reflected in the statement of need that we received from the Department of Community Health. The first phase is under the umbrella of increasing coverage options for uninsured low-income Georgians, and that entails conducting an analysis of existing or new ideas to increase coverage options for low-income as well as uninsured Georgians, and to enhance reimbursement rates for providers. And I'll do a deeper dive into each of these. We just want to lay the foundation and the groundwork for the work ahead. Once the options are identified, there's going to be an impact analysis that will be conducted, impact looking at both the financial impact as well as impact on health outcomes. So looking at from the financial side, the impact on the Medicaid program, the state budget providers, but also on health outcomes side, looking at Medicaid beneficiaries and low-income Georgians and the potential impact these options will have on the beneficiaries and the individuals. Then the next stage involves a focus on the quality improvement and service delivery and coordination. So we'll conduct an environmental scan to understand how beneficiaries interact with and engage with the various state health agencies, including DCH, but also those agencies where individuals seek and receive services. And then based on the scan and the findings from that scan, we'll identify opportunities for improvement focused specifically on how you can improve or how the agencies can improve that coordination, as well as improve the experience of individuals who are receiving services or who are seeking to receive services. These two phases really are driving towards the three opportunities that are noted in the House bill, which is related to the reimbursement and funding for healthcare providers, including a premium assistance program, improving quality of the services that are provided to low-income and uninsured population, and again, enhancing that delivery and coordination across state agencies. These are explicitly spelled out in the House bill. So on the next slide, yeah, here we go. We'll do a deeper dive into the project approach. And as I indicated, there are two phases to this work. So within the first phase, there are three sub-phases, which is the initiation, the environmental scan, and the impact analysis. With respect to the initiation, this is core project program management activity, which we will develop and flesh out the project plan, which will help to guide the work and the activities ahead, as well as developing a stakeholder engagement plan, because we acknowledge that there will be various stakeholders who will be need to be informed or impacted or made aware of the activity and the initiatives. So identifying who those stakeholders are, as well as identifying the objectives with respect to the types of communication and information that will be shared. So we'll work with the commission and at the direction of the chair to identify the various stakeholders that we need to keep informed and aware of the project, as well as the progress ahead. As indicated earlier, there is a report that is due December 1st, who will be supporting the chair and the commission on the finalization of that report, which will be submitted to the Governor and General Assembly. And then, similar to today's participation, we will, as needed and as asked, to attend the commission's meeting. The next phase involves the environmental scan. We know that there are leading, promising, and best practices out there with respect to coverage options. So we'll look across, comparable states, or at least desired states, as well as some of the evidence-based practices or information that's out there. And we'll compile this information. We'll supplement that with interviews with CHCC members, as well as within DCH stakeholders, to be able to identify from their perspective some of the practices that should be considered, i.e. some of the options that should be considered. Coming out of this will be an initial report, as well as the final report of those findings. Working with the chair and the commission, there will be three options that will be selected for inclusion in the impact analysis. And so there will be that financial analysis, as well as the potential impact on health outcomes. Again, supplementing this analysis will be soliciting input from key stakeholders in terms of their perception, understanding, or perspective on these selected options. And coming out of this, there will be a report. A lot of these phases, or all of these phases, there will be reports, initial as well as final reports, that will be generated from those. Then this takes us into the second phase, which is around the quality improvement and service delivery coordination. So with respect to the first sub-phase of this would be to define those agencies that are in scope. So identifying which agencies, Medicaid beneficiaries, individuals for soliciting services, interact and engage with. There's DCH, however, there are other agencies. So identifying which agencies need to be in scope, and then having interviews and conversations with these agencies to understand how individuals seek services, their experience with seeking services, and as well as the coordination interaction between the agencies. If agencies, for example, have created surveys that solicit feedback from beneficiaries or individuals seeking services, we will utilize that information to help inform and understand the experiences that individuals have as they are seeking seeking services and interacting with agencies. We'll also facilitate the interviews with key stakeholders across these agencies and draft the interactions report. At the discretion of the commission and the chair, we may identify individuals who are seeking services to then, do focus groups or just interviews and to have discussions to solicit their feedback and input and just, their experiences, understand their experiences if they're engaging with the various agencies, and to also understand if there are any opportunities for improvement that they have identified or that they would like to see in the system. From the assessment, we'll collect the gaps that we are seeing. Again, gaps in terms of how individuals are interacting or engaging with the agencies, gaps with respect to the coordination across and between agencies, and identify those improvement opportunities. We will address to or help to close some of those gaps, or potentially close those gaps. Again, coming out of this will be that initial report, which we will iterate with the commission and the chair, and the final report will be submitted from the commission to the General Assembly and as well as the governor. The last piece of this is the report compilation. It is noted that at the end of the commission's term, there will be a final report that will be submitted. And this final report will be a compilation of all of the reports that were generated to date, as well as the final report that reflects all of the findings, as well as the insights that were generated from the various activities along this roadmap. Underpinning all of this will be strong project management support for the commission, as well as for DCH, to ensure that the activities are being executed in a timely manner. If there are any risks or issues associated with execution of any of the activities, we will raise and obviously devise a mitigation to address those, just to make sure that we are staying on track and that the commission is adhering to its timeline. And continue to engage stakeholders in various communications, as I indicated previously, to facilitate the disbursement and distribution of information to make sure that folks are aware and attuned to the activities of the commission. So on the next slide, this is just another deeper dive into what I spoke to about the various phases, and just kind of splitting hairs a little bit here. So with respect to the first phase, as I indicated, there will be that assessment to understand what some of those coverage options include. So we will identify up to 10 states to review their policies, their strategies, and initiatives that have been implemented across the various states. Comparable states will work with the commission and the chair to agree on which states to review and assess. We'll also look at credible primary and peer-reviewed sources to compile information to help supplement the scan the information we find from the 10 states. As I mentioned, we will solicit feedback from stakeholders that are agreed upon by the commission and the chair to solicit their feedback and perspectives, and the findings from these activities will be compiled in that first report. With respect to the coverages, there will be 3 coverage options that would be considered for the impact analysis. We know coming out of the first phase, the first subphase, there will be several options for consideration, but for the purpose of the impact analysis, there will be 3 that will be selected for that deeper dive to understand, again, the impact on both the financial as well as health outcomes. And additional interviews will be solicited to seek feedback on those anticipated the impact on from the options, that are selected. Findings from this will be shared with the commission and the chair, and a report will also be generated for sharing with the governor and the General Assembly. On the next slide speaks to phase 2. Again, this is a deeper dive into slide on my end. Phase 2, John.
There we go.
Oh, one more. Okay. So as I indicated previously, this is really about understanding beneficiaries' interactions within and across various stakeholders. So we will look to create an experience, a journey map to understand how beneficiaries can interact and engage, seek services, and their experiences as they seek services across and within the different agencies. We'll compile the findings, another report will be generated. The findings will also help to inform the definition of any gaps and co-development of opportunities to improve those engagements and the experiences that constituents have. All of this will culminate in that December 31st, 2026 final report that will be sent to the governor and the General Assembly. The next couple of slides is just really the timeline by which these activities will occur over the next 2 years. So Sean, if you don't mind advancing to the next slide, please. There we go. So this speaks to both the key milestones as well as the new work products. The activities I covered, hopefully in detail. This speaks to when we are expecting to complete and when the commission's work for these particular deliverables will be completed and submitted. As you see, there is a strategic roadmap. Part of it has already started to be developed, as reflected in this presentation. That speaks to the work ahead, the key activities, milestones, and work products. The milestones and when the reports are due, as well as the key deliverables when they're due. For example, the environmental scan, when interviews will be conducted across both the first phase as well as the second phase. So this speaks to the first phase, and then the next slide speaks to the milestones and activities across 2026 for that second phase. Sean? Yeah, there we go. So as you'll see, the environmental scan, the health agency environmental scan, the report, the improvement activities, the associated report, and then the final consolidated report. Next slide. I think that's the last slide. Just, I must share this. I will read this verbatim. So apologies if I am, reading word for word. But EY will not make decisions regarding the coverage options, improvement opportunities, initiatives, options to consider and implement. EY will leverage publicly available and client-provided de-identified data for any analysis, including the impact analysis. EY's analysis and reporting is dependent on data quality, availability, and timeliness. And lastly, reports will be finalized, signed off, and submitted to the governor and the General Assembly by the chair of the CHCC. So with that, I thank you for your attention, and I will yield to the chair if there are any questions or comments. Thank you, everybody.
Thank you, Belinda. Thank you, EY team, Julie, for being on and walking us through that. Certainly these slides will obviously be available. There's a lot in there, a lot of timelines and things like that we're certainly share afterwards with all of you, so you can kind of get your bearings on where we're headed. I'm really excited about a couple of things in there in particular. Obviously year one work on provider reimbursement rates and options for expanded coverage, but even in the year two work, the Medicaid beneficiary experience journey and mapping, I'm kind of excited to go through that in a coordinated fashion. So I'll pause and open up commission members' questions, thoughts, feedback on this approach. Christy.
Hey, thank you, Chair Nagle, and thank you, Belinda and Julia. It's really nice to meet you, and this is really, really helpful. So thanks for putting together the roadmap. My question is, I know the initiative, so I'm with Georgia Health Initiative. We have several research products that are either coming out, kind of in the pipeline, or just out that I think would be helpful and could, we obviously don't want to be duplicative of work that's already taken place. So just a question about if we have research products that we think could help inform the work along the way, or other organizations have done some really nice research, how can we get that into the process so we don't duplicate good work that already exists out there that's really right in the sweet spot of what we're trying to get to?
I think I think start sharing, Christy. I would say,
Okay.
share through Sean and the commission, and they'll kind of be our conduit to EY and that team. And I think goes also into when the EY team does some of the stakeholder interviews with you and
Yeah.
others on the
Okay.
commission, Dr. Hyman and others who have substantive stuff to add. You can bring those to bear in those conversations. And then if at that point, if we feel like there are other experts that need to be included in those conversations, that would be a great time to loop them in as well. But yeah, we don't want to waste time reinventing the wheel if there's.
Yeah, and I
Yeah.
want to make good use of the budget that we were given to spend on this. So
That's right.
anything we can get in there would be great. Thank you. And again, nice to meet you and thank you for the work. And Kaylee and Sean and team, thank you too for getting the consultant on board. I know that was a lift.
Yay.
Nice to meet you as well, and thank you for that. We're looking forward to the information that you have to share.
Dr. Hyman.
Thanks. Yeah, so just echoing Christy's thanks for laying that out for us. And Belinda, I have to say it warms my heart to know that you have a background in public health before you got involved in some of the more current work, because I really think my own bias is that impacts the lens that you bring to this work. So I personally appreciate that. Obviously, what you gave us was a broad overview, and I realize that some of the questions I'm asking may be more granular aspects that are in there that haven't been shared, but just kind of a few high-level comments. Kind of understanding that the questions you ask often drive the answers you receive, and that if those questions are biased or tilted in a certain direction, it may impact what you learn. But in contrast to our esteemed chair, who's excited about you're looking at enhanced reimbursement rates for providers, and I'm a family doc, so I appreciate particularly the primary care doctors need to be adequately reimbursed. When you look at coverage options and enhanced reimbursement rates for providers kind of in the same sentence, I worry that concern about reimbursement for providers might bias what you learn about coverage options. So I just want to suggest that we be very mindful of not conflating those as one question to answer together, but the primary question from my perspective is how do we close the coverage gap and ensure that the 250,000 Georgians that have no opportunity for coverage have greater options. And in the context of that, also looking at what that means in terms of access more broadly and the importance of making sure that provider rates are both adequate and equitable. So again, and none of these, candidly, Belinda, probably require response unless you want to. So
Sure, I can respond to that. So typically when we are conducting the interviews, we create both the questions as well as the interview guides, and we'll be happy to share those questions with the group just to make sure that we are addressing your concerns, right? We don't want to, introduce any bias or eliminate the bias, potential bias that may be introduced as a result of the questions that are being asked. So we will produce the interview guide with the questions, and we'll be happy to share it with the group for you to provide feedback. Say, well, no, this question doesn't exactly get at it, or ask this question differently, or, however, welcome the feedback before we actually proceed with the interviews.
Right.
And thanks, Dr. Hyman. I think that's a fair point. I think that's a good point. I think there are multiple angles to this on both sides, and the coverage is different than reimbursement. Absolutely. I agree with you on that. I think I just tend to use the language that was in the bill, but you're right. They're different. So thank you.
And again, thank you. For the impact analysis, and again, I suspect the more granular details there, you're looking at both financial and health outcomes. Obviously, there's a range of perspectives you can bring to financial analysis. There's the financial impact to consumers, the financial impact to providers, financial impact to the state. So again, it would just be helpful as we go through that process to think about which perspectives you'll be bringing to that analysis, because I think all of them are important. But just want to make sure in particular that the consumer perspective is not lost in that analysis. And then I know that you're looking at agency efficiency and talking to beneficiaries about their interactions with agencies. We have a number of people, as you're probably aware, in our state that don't have the opportunity to interact with agencies because of barriers to entry. So again, I would just challenge you to think about how to get perspectives of those who would very much like to have a relationship with TCH, for example, but don't have that opportunity because of barriers to entry. And the last thing I would ask is, as we look at other states and as we look at analyses of the range of options related to Medicaid, that we keep in mind key populations in our state that are experiencing profound health inequities. And I'm thinking particularly about maternal child health, low-income people living with HIV/AIDS, low-income people living with mental health and substance use disorders. And again, that it's not just a overall assessment of the impact, but that is particularly focused or has, in addition, particular focus to populations in our state that are experiencing health inequities. Thank
Thanks,
you for
Dr.
that.
Hyman. Those are all really, really thoughtful responses. Rusty, I think you're next.
Yeah, just real quickly. No, I think it's an excellent approach to getting the data together and hopefully proposing some modifications to our current system. But I did want to, Belinda, make sure that I'm sure you will be doing both a vertical analysis of amongst the agencies as to how they coordinate and interact, but also vertically down to the ground, and not only with the people who happen to be part of the system, meaning the beneficiaries who actually find their way through the system to get benefits, but also other organizations. Like in Savannah, we have something called Union Mission that takes care of a lot of our homeless folks down here. Great, I would think, resource to find out how actually the homeless and the near homeless in this community get approached and can develop that relationship to get the benefits that they need to get from a healthcare standpoint. So just wanted to really put that thought out there that it's efficiency, but it's also, how do you get those guys that are sleeping under the bridge? How do you get those folks who are healthy right now and don't think they need anything, and then all of a sudden they have a problem and need to interact with the healthcare system? That was my entire
Good.
thing.
Thank you, Rusty. Delvecchio.
Good morning. Thank you, Kelly, and my sincere apologies for my tardiness here. I appreciate the overview as well, Belinda, and several of the comments of my colleagues. Definitely want to underscore Dr. Hyman on the piece around coverage and access, if you will. That while I think payment rates and other things are kind of a leading indicator of access and certainly important as a means of ensuring that we don't create or perpetuate a notion that coverage in itself connotes access, that people, if we were able to get them in a program, that they actually could get the level of preventative primary care and obviously any further advanced care that they need. So I think those things do have a connection that is inextricable. So I appreciate that. I apologize. It may be there, and if it is, just tell me and I can go back and look at it later. What I saw when I dialed in here is that there was a plan, or the approach was that we were going to start with about 10 different sort of options, and then at some point in the process, that 10 would go down to 3, and those would get sort of further vetting, if you will, from the impact analysis perspective. If I followed that correctly, please confirm that. But then also, if you spoke to the sort of the process by which the 10 become 3, is there criteria that's already established now, or is that a part of the initial process?
Yeah, probably part of the initial process based on what just seems like we have all come to some conversation or through individual feedback with EY on where there's the most interest, where there's the most opportunity, where there's maybe the most feasibility on what, really could be possible, and or if there are things that we've already looked at as a state or other states have looked at or vetted. So I think it's just cast a wide net, and then let's come together and figure out kind of collectively what makes sense to focus in on, since we've both have limited time and really limited resources with our consultant to go in and go in deeply.
I appreciate it. And so the last thing I'd say too is kind of with that context in mind, which I totally agree with. I think, I love the fact that we're going to be looking at multiple agencies, particularly on the public health side. And I think that sort of speaks to comments that Rusty was just making, in the sense that, I think if we're focused on the healthcare delivery side as the kind of the sole point, or even the overwhelming point, we'll miss the piece of a lot of what we hope to be able to accomplish in a very much more sustainable and proactive way, is to keep people healthy, or to have a robust enough public health system that allows for better sort of upfront things, and we don't have such overwhelming, chronic, expensive things happening downstream. That's going to happen. That's life. We get it. But I think, as we're looking at the different options, the extent to which that can color or influence the effectiveness of the things that we're endeavoring to propose or recommend, I think will be key. So I appreciate that.
Any other thoughts from the commission members? Thank you all so much. I think, Sean, unless you have sort of anything else for us, I'll just kind of wrap us up today. Again, we knew it would be a little bit more brief, because this is, I feel like this is a good roadmap ahead. There's a lot to be done in here. This will require a lot of us collectively and individually. So please be on the lookout for communications from Sean and the team at DCH. Probably will be the conduit with the folks at EY, but there's certainly a lot of work for us to do and engage in the weeks and months ahead. That timeline, and again, we'll get these slides posted publicly and shared out to you, so you'll be able to see kind of here in the next few weeks. I think that we'll be able to a little bit work backwards of knowing when we have a next kind of deliverable due or a report due where we need to be, which will help kind of inform when our meetings need to be collectively and what that cadence will look like. And so I think hopefully sometime in December, I would love it if we can figure out when the next couple of meetings might be and figure out and go ahead and get some scheduling done. I think that would be great for us. So we'll talk to the team about that. I mean, it probably goes without saying, but I'm going to say it anyway. This is a very interesting time to be doing this work. We are in sort of a unknown territory and changing dynamics in a federal landscape. And so we're trying to design and look at options that may shift in the middle of some of what we're even looking at, and what's possible, or our analysis and things may change as new kind of federal policies and priorities are kind of shared, and we learn of those over the next several months. And so we'll just have to be dynamic. I've said it before, and it bears repeating of, our job is to my job is to stay focused on the policy and the options and how we continue to move Georgia forward. And so we'll do that regardless of what things look like. We'll continue to look for options. So I appreciate you all being in this with me. I recognize and appreciate that we all have day jobs, and this that we've laid out today is a lot of work and a lot of substantive work. And so appreciate your willingness to continue to serve and dive in it deeply with Belinda and Julie and the team. So without further questions, again, be on the lookout in the next couple of weeks for further communication from DCH and folks. But really appreciate y'all today. And if you have, after you digest this, have further thoughts or comments, don't hesitate to send them and start thinking about the resources that you have, and we'll be in touch. Sean, anything from your end?
Nope, I think you captured everything.
All right. Thank you all so much. We appreciate you.
Thank you.
Thank you.
Thanks.
Thanks, Kaylee. Thanks, Sean.
Thanks,
Thank
everyone.
you. Bye-bye.